All right. Well, good morning, everyone. Thank you all for attending today's webinar sponsored by the ATS Assembly on Allergy, Immunology, and Inflammation. My name is Erica Orsini. I'm an assistant professor and associate staff physician in the Department of Critical Care at the Cleveland Clinic. And I'm very excited to be moderating today's discussion, where we will focus on the AII Research Abstract Winner Presentations, Part 1. So this webinar will include presentations by 3 abstract winners from the International Conference in 2025. And then we'll also be joined by an expert panelist, Dr. Fernando Holguin, who is a professor of medicine and head of the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado. So we'll ask each presenter to speak for about 10 minutes, and then we'll have about 2 to 3 minutes after each speaker for comments and questions. Please feel free to use the Zoom chat function, or you can raise your hand, and then we'll be able to get to your question. And this session is recorded, and it will be posted on the ATS website. So without further delay, we can get started with a presentation by Dr. Leander Jonckheere. He is a PhD fellow and is at the University of Ghent, and he's going to be speaking to us about his abstract entitled Cystic Fibrosis as a Modulable Model for CFTR-related Immune Dysfunction.
Thank you very much for the kind introduction, Dr. Orsini. I'll just try to get started by sharing my screen. Hi, everyone. I would just like to start out again by thanking the organization for giving me this wonderful opportunity to present my research on using cystic fibrosis as a modulable model for CFTR-related immune dysregulation. I have no conflicts of interest to disclose. So in cystic fibrosis, due to a faulty CFTR channel, there is, of course, buildup of thick, sticky mucus, and this promotes local airway inflammation, which we all know. But there is also an important degree of systemic inflammation present in cystic fibrosis, and this has been my area of research. And even more correct, I think, than just talking about inflammation is to talk about systemic immune dysfunction, because we know that, for instance, in CFTR deficient monocytes in CF patients, due to the ionic imbalance that occurs, there is on the one hand increased TNF signaling, which of course promotes increased systemic inflammation, but on the other hand, there is decreased interferon signaling, which reduces the body's ability to respond to infections. The CFTR modulators, which I'm sure a lot of you have heard about, have worked wonders in the clinic, and they've produced clear clinical benefits by, on the one hand, correcting CFTR trafficking to the cellular surface, and on the other, also potentiating the function of CFTR once it reaches the surface. But what we don't really know is what its effects are on systemic immunity and inflammation. An important concept also with regard to CFTR dysfunction is that it exists on a clinical spectrum. So on the severe right-hand side of the spectrum, we of course have full-blown CF, but in between we also have these healthy or presumably healthy carriers of CFTR mutations, which represent a large yet clinically silent segment of the population. About 4 to 5% of the population in Northern Europe and North America are actually carriers of a mutation. We call these the obligate heterozygotes. And recent studies have come out suggesting that they might actually not be that healthy. When we look at a population level, they are at an increased risk for almost every CF-related disease. So we ask the question, can even partial CFTR dysfunction also have a measurable impact on systemic immunity and inflammation as it does in CF? And so how we approached these concepts, we investigated patients with CF before they were started on triple modulator therapy, and also once they were started on the triple modulator therapy. And I think unique to our approach, we used genotyped healthy control. So usually you genotype mice. In Belgium, we also genotype our humans. And we included both healthy F508del carriers, with F508del being the most frequent mutation in CFTR, and also proven non-carriers of the most frequent mutation in CFTR. We collected serum of these patients and also PBMCs for further analysis to capture the full spectrum of CFTR dysfunction in our study design. So on the serum, we did a multiplex cytokine analysis for 10 major pro-inflammatory cytokines. And on the PBMCs, we used a single cell analysis technique called site sequencing. So where we can both sequence, of course, the intracellular mRNA within each cell, but also we have antibody-derived tags that are targeted against surface markers, which also allows us to capture the full surface transcriptome of each cell. And then after a couple of months of bioinformatics analysis, you get something that looks something like this, which is called a UMAP, where every single dot represents, of course, a single cell, and the colors denote different cell types. And when we just look at the global level, and we'll dive into this later, we can see here the PBMC immune composition profile. So from the left side, the CF patients at baseline, and all the way to the right, we have the non-carriers. So with augmenting CFTR function, if you will, from left to right. And we can see that there's really distinct immune profiles emerging associated with the CFTR functionality. Let's first zoom in on the classical monocytes over here, because we know that they are key role players in the pro-inflammatory, but also anti-inflammatory responses in CF. And so when we looked at the transcriptome at the single cell level of these monocytes, at the genes that were downregulated, they were mostly related to TNF signaling. And also the pathway analysis confirmed that TNF signaling was being downregulated in CF patients that were started on ETI. And so there seems to be a less prone monocytes towards inflammatory responses. When we confirmed this at the protein level, so in terms of cytokines in serum, we also saw a significant degree of TNF-alpha in serum in these CF patients. When we move to the right side of this volcano plot, we saw actually that genes that were upregulated were genes that were all related to type 1 and 2 interferon signaling, which is interesting because we know that in baseline in CF patients, the signaling was deficient. Also, when we looked in serum at the protein level, we saw that in a subset of patients, the CF patients that were the most inflamed, if you will, at baseline, we saw a significant increase in interferon gamma. So there seems to be this sort of recalibration of systemic inflammation in CF due to the restoration of CFTR. We went even further and we looked at intercellular communication. So how do immune cells crosstalk at baseline in CF patients, and how does this change on ETI? We use a ligand receptor analysis, which is called multi-niche-net. And so the bottom half of the circle are the sender cell types, and the top half of the circle are the receiver cell types. And the monocytes, the classical monocytes, CD14 positive, are the large dark orange population. And what we saw at baseline was that the signaling mostly occurred through S100A8 and 9, which is also known to be calprotectin, so pro-inflammatory signaling towards different PBMC subsets. And very interestingly, we observed once patients were started on ETI, and these were the same patients, so we could compare this in a paired fashion, we saw that the signaling shifted, so away from the pro-inflammatory signaling towards TGF-beta mediated signaling, which is known to promote tolerance and also formation of Tregs. And we saw that this signaling was most pronounced from monocytes towards central memory T cells. So again, there seems to be a recalibration of the immune response. Let's now dive deeper into the difference between carriers, non-carriers, and CF patients. Interestingly, what we found that actually healthy carriers of a single CFTR mutation, so the F508del carriers, were much closer to CF patients than to non-carriers in terms of immune cell distribution, and particularly with regard to one very interesting subset of T cells, mucosal-associated T cells, which are an innate-like T cell population, which are critical for mucosal immunity in CF, and which are known to be depleted in CF. And we saw that these were also equally depleted in healthy carriers, and they were at normal levels in non-carriers. When we looked at IL-6 in serum of carriers versus non-carriers, what we also found that there was a slight yet significant increase in IL-6, so suggesting chronic low-grade baseline inflammation actually in these healthy carriers. We also wanted to confirm our single-cell findings by flow cytometry, mainly looking at differences in T-cell lymphocyte subsets between non-carriers and carriers. And this is a flow sum tree. So each node in this tree represents a distinct T cell cluster, and by using the pie charts that you see on the right, those are the MFIs, so the mean fluorescent intensity for different markers, we can annotate these clusters, right? And so when we look specifically at the mucosal-associated T cells and how they differed in abundance between non-carriers and carriers, we could see that they were almost completely depleted in carriers, confirming our findings from the Cytomegalovirus experiment. So what would I like you to remember from my talk today? Just keep in mind, I think that systemic immune dysregulation and inflammation are core features of CF in addition to the airway disease. And it appears to be so that these phenomena are driven at least partly by intrinsic CFTR dysfunction. So there is on ETI, through partial restoration of the CFTR function, a reduction in systemic inflammation, but also sort of promotion of regulatory immunity and antiviral immune responses. And interestingly, in clinically healthy carriers, carriership of even a single mutation is associated with quite subtle but significant CF-like immune changes, so the low-grade inflammation and depletion of the mucosal-associated T cells. So I think our findings add to the understanding of the role of CFTR possibly in our human immune system and could have implications beyond CF with CFTR-related conditions such as bronchiectasis. And with that, I would like to end and thank all of my collaborators at Ghent University, Ghent University Hospital, and the VIB Inflammation Research Center. Thank you so much, everyone, for your attention, and I'm happy to take any questions, but I'll leave that to the moderator for the timing. Thank you so much.
Thank you. That is very interesting, very important work. So thank you for presenting. And if anyone has a question, you can raise your hand. I might just get started because I think this is an extremely interesting area. And I think when we're looking at the monocyte and the macrophages in people with CF, we always wonder, like, what's the relative contribution of CFTR dysfunction and the relative contribution of chronic infection? And I know that we do see a lot of people, when they go on modulators, they'll have improvement in chronic lung infections, and some even go on to clear them. So how do we differentiate in your research, what is the relative contribution of each to the decrease in pro-inflammatory signaling?
Yeah, this is, of course, I think immediately gets at the core of one of the problems, of course, of the research is that we are working with real life patients, and we haven't done a lot of in vitro validation. So I think really, if you want to disentangle what is due to intrinsic CFTR dysfunction and due to just inflammatory load decreasing and also bacterial load in the lungs decreasing, you really have to go to an in vitro model where you take your PBMCs and then you restore them in vitro, so you can add the modulators in vitro with ETI, and then see whether you see similar changes that occur in your monocyte fraction, right? Because I think that's the only way to disentangle, like, what is happening here. Is it due to restoration of CFTR function, or is it due to just reduction of the bacterial load in the lung? But I think our findings in healthy carriers, of course, suggest that there is a role for intrinsic CFTR dysfunction in systemic immunity, I think, because these carriers, they don't have established lung disease, they don't have bacterial load in their lungs, or shouldn't have. So I think they hint at the question of whether there's a role for intrinsic CFTR dysfunction in systemic immunity and inflammation, also in monocyte function. Yeah.
Thank you. That's very interesting. I guess we'll see if in the future we start to see some of these heterozygotes on modulators for some of the, being at risk for some of the conditions you mentioned, and then we can maybe answer that question with human studies. So thank you so much. I don't see any other hands raised from the audience. We will have more questions and discussion later, but I think we will pivot to our next speaker. We have Dr. Leonoor Boers. She's a research associate in intensive care medicine, coming to us from Amsterdam in the Netherlands, and she's going to speak on pulmonary reactivation of herpes simplex virus and cytomegalovirus in patients with acute hypoxemic respiratory failure. All right, take it away. Thank you.
Thank you for the kind introduction. Yeah, I'll start right away. So while my home institution is the University of Amsterdam, this research was actually conducted at the University of Washington in Seattle last year. So here I had the great opportunity to do a research fellowship, and this is the study that I'll present today. I have no conflicts of interest. So in patients with acute lung injury, pulmonary secondary processes can sustain inflammation and worsen injury. Bacterial and fungal infections are already well recognized, but human herpes viruses such as HSV and CMV remain controversial in this population. So are they innocent bystanders or active contributors to lung injury? And HSV and CMV could remain latent after primary infection. And in the ICU, factors like critical illness, mechanical ventilation, and immune dysregulation can trigger this reactivation. So in this population, we're actually looking at a vicious cycle, as you see here. Lung injury and immune dysregulation can drive reactivation. And in turn, reactivation can worsen the lung injury directly or through ongoing inflammation. In one of my previous studies on COVID-19 related ARDS, we observed frequent pulmonary viral reactivations for both HSV and CMV. However, the HSV viral loads were rather high. In literature, a threshold of 10 to the 4th copies per ml is generally considered as being pathogenic in different populations. And we saw, and what you also see in these plots, is that for HSV, the viral loads were rather high, which is shown in orange, compared to CMV. We also saw that the higher HSV viral loads were associated with increased mortality. And also we saw that the HSV reactivation was associated with increased alveolar inflammation. So in this current study, we wanted to extend our previous findings from COVID ARDS to a broader population of patients with acute hypoxemic respiratory failure of any cause, with a focus on early reactivation. So our hypothesis was that pulmonary reactivations are not specific to COVID-19, but also occur commonly in all-cause acute respiratory failure and are associated with immune dysregulation and worse respiratory outcomes. So at the University of Washington Hospital, we conducted this study, including mechanically ventilated patients with acute hypoxemic respiratory failure. And we only included patients that were seropositive for HSV and or CMV, so that they were at risk for having a reactivation. The patients underwent early BAL sampling, and it was repeated after 4 days when feasible. And we withdrawn paired blood too. The HSV and CMV viral loads were quantified by qPCR, and in both BAL and blood, the protein biomarkers were measured. And from blood, we also did single cell analyses with Cytomegalovirus. In total, we included 128 patients, of which 84% were seropositive for HSV and only 53% were seropositive for CMV. So going on with these cohorts of seropositive patients, 19 out of the patients, the seropositive patients for HSV were had a HSV reactivation, and only 10 patients had a CMV reactivation. So when we plot the same graphs, we again see that there are especially high counts and viral loads for HSV compared to CMV. So out of all patients, 13% of the HSV of the patients had an HSV reactivation classified as high viral load compared to 0% of the CMV reactivations. And in 5 patients who had a repeated BAL in the first 10 days of mechanical ventilation, we see that the viral loads all increased over time. So on the x-axis, you see the days from intubation until BAL, and on the y-axis, you see the viral load. And then the connecting lines of the 2 samples of 1 patient. And we see that these were all increasing. So this means we may not even have captured all reactivations since we focused on early sampling. Looking at the clinical outcomes, we see that HSV reactivation patients demonstrated worse respiratory physiology compared to the non-reactivated patients at the time of reactivation. So higher PEEP levels, worse oxygenation index, and a lower S to F ratio. And also patients with HSV reactivations had fewer ventilator-free days and longer ICU length of stay compared to those without HSV reactivation. When we cross-sectionally evaluated the biomarkers at the time of reactivation, we see that in blood, the biomarkers were mainly increased. So we see an inflammation in blood with reactivation. So in this plot, you see on the right corner of the figure, the biomarkers that were increased in HSV reactivation, and the gray dots were non-significant. Sorry, the wrong side. If we look at the alveolar compartment, we see that the biomarkers were decreased in HSV reactivated patients. So they were in the left corner of this plot, so meaning lower in HSV compared to non-HSV, which is interesting. For example, in this specific marker PDL1, which is increased in blood and decreased in the alveolar compartment for HSV reactivated patients. We also evaluated the cell composition between the 2 groups, and interestingly, we saw that non-classical monocytes were reduced in reactivated patients, whereas regulatory T cells and naive CD4 T cells were increased in HSV patients. So to conclude, in this study, we found that viral reactivations are common in mechanically ventilated patients with acute respiratory failure of any cause, and particularly HSV with higher seroprevalence and higher viral loads. And this was the same as in our previous COVID-19 cohort study. We saw an association between early pulmonary HSV reactivation and worse outcomes, specifically fewer ventilator-free days and longer ICU stays. And we also observed elevated systemic immune mediators in the reactivated patients and altered cellular inflammation. So although we observed a similar distribution of high HSV viral loads compared to CMV, compared to what we saw in the previous COVID-19 cohort, the overall number of HSV reactivations was a bit lower in this study, but this is most likely because of the earlier sampling in this current study design. And the fact that we see rising viral loads over time suggests that some patients may have reactivated later outside of our sampling window. But what is important here is that even early HSV reactivation was already linked to worse outcomes. So the differences in lung-specific outcomes support the idea that HSV reactivation may impact pulmonary recovery. And this raises the question whether earlier recognition and potentially earlier treatment could help to reduce alveolar injury in these critically ill patients. And as shown many times in the literature already, we again demonstrate here that the pulmonary host response is different from the systemic. And we even see opposite directions of association. So this shows the importance of studying alveolar environment more closely, especially since this is a pulmonary disease with worse pulmonary outcomes. So to address this and to explore these mechanisms more in depth in both the alveolar and systemic compartments, also for the cellular compositions, we are now conducting a study in Amsterdam with larger numbers of paired alveolar and blood single cell samples. And we hope to share the results very soon. I wanted to especially thank my supervisors, Eric and Carmen, for their mentorship during my fellowship at the University of Washington. And I also thank my home institution, team, and supervisors. And thank you for your attention.
Thank you so much, Dr. Boers. That was really interesting, and I think this could really change patient care. I see we have a hand raised.
Dr. Boers, very nice work. Congratulations. This is a lot of work, clearly. One of the things I had is more kind of in the realm of clinical epidemiology. Do you know, or can you tell us a little bit about, so there's, I think, very clear evidence that reactivation is associated with worse outcomes, but do we know what factors are associated with reactivation itself? In other words, what is the role of age and comorbidities, for example? Is reactivation functioning as something that's more of a indicative of the fact that the patient is sicker, or is it truly reactivation that's driving the worst outcomes?
Yeah, that's an interesting question, and that's also very hard to explore in observational studies, like what is the causal relationship, of course. It could be that the reactivation is a sign of critical illness. But when the reactivation is causing more alveolar injury, then this will cause a persistent state of this injury. So whether it's the reason is that the patient is sicker and gets a reactivation, I think that it's important that because the reactivation, the recovery of the patient will probably remain worse. But yeah, it's a good question that it needs more studies and bigger numbers of patients, I think, to specify more concretely what the causal pathways are.
Thank you.
Okay, and I see we have a question from one of the attendees, Dr. Medhoff.
Actually, both presentations were fantastic and really hard work to do. So congrats to everyone. Just a quick question. Sometimes we see HSV reactivation in, oral lesions or tracheitis or LFT abnormalities. Were any of these patients showing these other clinical signs, or were they all just sort of subacute detection of this without sort of clinical signs of infection? Do they have any clinical signs of HSV infection? So oral lesions, tracheitis, sometimes we see a really intense tracheitis, or LFT abnormalities, signs of actual infection, or were these just detected just in the lavage without any clinical signs of HSV infection?
Yeah, without any other signs of HSV infection.
Okay.
It was just by the BAL that it was measured. Yeah.
Great. Okay, thank you.
Okay, and I think we have time for one more question before our next speaker, Dr. Villabona-Rueda. You want to ask your question?
Hello, that was a great talk, amazing work. I just have a quick question related to the PDL1 finding that you were showing at the end. That was kind of interesting that you saw that there was an increase in the systemic or the PMCs and decrease in the alveolar space. Have you characterized the specificity of this finding? This is related to alveolar macrophages versus like peripheral monocytes, or this is just like in general finding that you saw in the alveolar space? Like, is this specific to alveolar macrophages? That would be my question.
So, sorry, if I understand correctly, your question is if this is the PDL1 is for alveolar macrophages, or
Yeah, I mean, like the heterogeneous response that you saw, if I'm not mistaken, there was increase in peripheral blood, but decrease in the alveolar space. Like, is that like a specific for alveolar macrophages versus like recruitment of peripheral monocytes, or this is just a general finding in the alveolar space that you saw in these patients?
So these results were on protein biomarker levels, so not the cellular component. We could say anything about the pathways there. But yeah, we know that the compartments and the immune responses act very differently. How they specifically differently in this population, I don't know if this is something that, yeah, we could see more, and I'm really eager to see if in the Amsterdam cohort that we are currently conducting, we could find same signals and dive deeper into the cell pathways behind it.
Thank you.
Okay, and so then that's a great segue into our final speaker today. We have Dr. Andres Villabona-Rueda, who is an assistant scientist in the Division of Pulmonary, Critical Care, and Sleep Medicine at the University of Miami. And he's going to share his work on exposure to burn pit derivative leads to myeloid dysregulation towards a pro-fibrotic phenotype in mice.
Hi, thank you for the introduction. And yes, as you were mentioning, my name is Andres Villabona-Rueda. I am originally from Colombia, but I work here at the University of Miami as an assistant scientist. And today I want to talk to you about our ongoing project that we have in collaboration with the University of Minnesota and the VA, where we have developed a model that closely resembles the lung pathology that we see in people who were exposed to burn pits. And our idea was to explore the immune phenotype of this response. So I have no conflicts of interest for this talk. And the reason why we wanted to study this is because the effects of the burn pits came due to the history of exposure of millions of US veterans who served during the Wolf Gore era and post 9/11 deployments, where people, especially militaries and soldiers, were repeatedly exposed to toxic airborne hazards and open burn pits. And here in panel A, I'm showing you a map where the biggest burn pits were located in the Middle East, highlighting which were closely located to US military bases. And in panel B, we see the Balad Air Base in Iraq, which was one of the largest documented burn pits that was equivalent to 7.6 American football fields. So these burn pits generate airborne particulate matter, toxicants that come from the incomplete combustion of waste, which after exposure leads to inhalation and subsequent depositions in the lung. And the resulting particles have a diameter between 2.5 to 10 microns, which can travel deep into the airways and the alveolar spaces, which is the small airways. And that big accumulation of particles initiates an inflammatory response, which over time contributes to persistent lung and systemic inflammation that clinically leads to something called chronic to deployment-related constrictive bronchiolitis, which clinically, during the first stages, the patients may present mild dyspnea, especially during exercise, and the PFT may show a pattern that is consistent with mild obstruction, but with chronicity, it could lead to a restrictive pattern. So the deployment constrictive bronchiolitis has a patchy focal involvement that differs a little bit from the regular constrictive bronchiolitis. That is why it is called post-inflammatory, but it still leads to a high burden of morbidity. So our idea was to create an animal model that closely resembles the deployment-related constrictive bronchiolitis, which could serve as a platform to study mechanisms and therapeutics. So therefore, we wanted to assess the pathophysiological changes in the lung and the immune biology of this murine model that simulate the burn pit exposure. So to model this, we use three components, which was carbon black, or CV, that I'm going to call, naphthalene, which I'm going to call N, and silica, which I'm going to call S. So altogether are called CV and S. So I use 10 to 12-week-old male and female mice, and we also included sex as a biological difference, who underwent intranasal exposure of these components. And we expose these animals every other day for 2 weeks, allowing a 2-week rest. And then we harvest the tissues to explore both a functional and cellular assessment. So for the functional assessments, we use something, a new technology that is called 4D CT scan, and we use pulmonary function tests, which what we use is the FlexEvent system. And for the cellular assessment, we use a spectral flow cytometry and histology and cytology. So when we look at the CVNX exposed, the first finding that we have when looking at the CVNX exposed mice, we saw that there was an increase in ventilation deficit and heterogeneity. And for this, we use this system that is called 4D CT scan. And this allows a quantitative functional imaging that is not only limited to the lung structure, but also how well the air moves in and out at multiple spatial scales and across the entire respiratory cycle. So we could see like there's this being that basically during the respiratory cycle like gets multiple images. It's very similar to what we see with the CT scan. And then it calculates multiple variables that allow us to identify something that is called ventilation deficit and ventilation heterogeneity. So the ventilation deficit are the regions and the lung that show reduced or no air volume change with both inspiration and expiration, while the heterogeneity assess the variation of how different these lung regions ventilate. So here in this image, we could see like when the regular lung should look like green with a normalized specific ventilation of 1. And when we start seeing differences in the ventilation, then we start seeing like under ventilation or over ventilation. Under ventilation would be like 0 or red, and higher ventilation would be 2. We saw more heterogeneity in the CVNX exposed mice, and when we quantified that, that was clearly very different. So to better understand the effect in the lung function, we perform PFTs with the FlexEvent system that I was mentioning before. So I know that this is a lot of data, so I'm going to try to walk you through this data across. So if we take together the increase in the resistance, elastance, tissue damping, tissue elastance, with decrease in compliance in the PV loops and the inspiratory capacity with an unchanged Newtonian resistance, it is apparent that it's very consistent with a restrictive lung disease. So when we look macroscopically at the lung, we saw the deposition of these black particles. That was very evident, and the cellularity in both the BA and the lung were higher in the CVNX exposed mice. And when we look at the histology, we saw those patchy areas in the airway when looking with the hematoxylin eosin, and also we see these black particles very rounded around the peribronchial and septal space with an ongoing inflammation, which was consistent with the finding that we see in the pathology of the patient with deployment constricted bronchiolitis. And when we also assessed the Mason trichrome, we saw that there was starting to see a higher deposition of collagen in those spaces, which eventually in patients is also evident that it caused fibrosis. That was more evident in that area. And to better understand which cells were increasing the alveolar and the lung space, we employ spectral flow cytometry, and we saw like very specifically increase in the cellularity of both myeloid and lymphoid cells in both the alveolar and lung space. And when we deeply look at the non-immune cells or CD45 negative cells in the lung, we saw that there was increase in the CD326 cells, which are epithelial cells, and there was no change in endothelial in fibroblasts and endothelial cells. But what was strikingly different was that there was increase in the C140 alpha cells, Ki67, which Ki67 is a proliferation marker in the fibroblasts, which is the C140 alpha, which suggests that despite there was no difference in the cellularity of the fibroblasts yet, there was starting to increase the proliferation. So we also look at the alveolar macrophage phenotype profile. Our lab is very interested in macrophage biology. So we wanted to see if there was different in the phenotype of macrophages. So we saw that there was increase in migratory markers such as CCR2 and CD140, increase in pro-fibrotic markers, and that was given by scavenger receptors such as CD36, Dectin-1, and MERTK, and decrease in C71. And we saw higher expression of TGF-beta, which is also consistent with the pro-fibrotic pathway that it's very well described in the literature. So in conclusion, I hope that I have convinced you that we have developed a model that closely resembles what we see in the deployment-related constrictive bronchiolitis, and that was given by the ventilation defects in both the small airway and parenchymal involvement, higher cellularity in both the lung and the alveolar space, and a phenotype that is consistent with fibrosis, and that the alveolar macrophages were playing a role towards this pro-fibrotic phenotype. So we hope that this model is going to help us to investigate more mechanisms and find potential targets to decrease the progress of this disease. So I want to thank all of our group here and our collaborators, so I can take any questions.
Thank you. That is very interesting work. I was just curious if you guys had looked at all how your pro-fibrotic macrophage from the burn pit mouse model compares to more conventional models of like IPF, like bleomycin mouse models, and if there's any overlap in those mechanisms such that there may be unified therapeutic targets, or if they're distinct entities such that they kind of need different paths.
So we have started to explore that, and for now we have just got single cell RNA sequencing data that we are comparing with the regular model of pulmonary fibrosis, which is the bleomycin. And so far what we have seen, and this is still a work in progress, is that because the pulmonary fibrosis tends to be more complex than disease, is that the TGF-beta pathway is the most the commonly affected one in both, which is also consistent with the data that we got from flow cytometry. But that's still like something that we are working on. So far, the TGF-beta pathway is the most remarkable one that has been shown.
Thank you. And now we do have a question from Dr. Holguin.
Hello, Dr. Holguin.
Andres, very nice work. Very, very
Thank
nice.
you.
You know, I have a couple of questions. One of them is, you know, the physiology that you showed us suggests that there's probably both airway and parenchymal effects. Do you have a sense of how much effect you're seeing physiologically in small airways? Were you able to estimate small peripheral airway resistance versus, for example, total airway resistance? And the second question is perhaps a more complex one, but, you know, we have a deployment respiratory disease study in humans, and the disease shows that there's a tremendous amount of heterogeneity in degree of airway inflammation, like especially if you look at, for example, across the T2 spectrum of inflammation. Some patients have it and some patients don't. And I wonder how a murine model could recapitulate some of that heterogeneity of inflammation that we see in patients. And it's a tough one.
Yes.
If you have any idea.
So interestingly, well, so far we, by using the 4D CT scan, we could assess the peripheral versus central airway resistance, not airway resistance, but heterogeneity in the ventilation. And we saw that there was both involvement in, sorry, I'm going to correct this, in the flex event data. We can see peripheral versus central resistance, and it was both affected. So so far, we have not been able to estimate which is the one that is playing the most important part, but we want to explore that.
Thank you. Any thoughts about inflammation heterogeneity?
When you mean inflammation heterogeneity is related to both the peripheral and the central?
No, I was talking about, we see in patients, for example, when they come with deployment-related airways disease, that some of them fall in T2 spectrum, some of them are definitely not in the T2 spectrum. And I wonder, it's complicated. Maybe it's related to the degree of exposure or the underlying development of allergy.
Yes. So one of the very big difference that this model has is that it's very post-inflammatory and it's very patchy. It's not as generalized as some other deployment-related respiratory diseases. So I think that that makes this particular condition different to the rest. So I will have to like develop a model that recreates a higher kind of inflammation to be able to see heterogeneity. I definitely think that this is going to be kind of different pathway to like other deployment-related respiratory diseases, because it tends to be very patchy and not as generalized as some others can be.
Thank you.
Okay, well, I would like to thank all of our speakers for their absolutely excellent presentations. I really enjoyed all of them, and I think they're all very clinically relevant. So very excited to see where these projects go. We do have a bit more time, so I would love to open it up to the audience if there's any other questions or comments or discussion among the panelists. And of course, Dr. Holguin, we'd love to hear any more commentary that you have as well.
Yeah, are there any more questions? No? Well, first of all, as the chair of the AII Assembly, I just want to really thank you for spending time presenting your abstracts and congratulate you on your work. I mean, today I agree with Erica. We saw a really, really wonderful display of both, translational, basic science, and clinical work, and so that reflects really the membership of our assembly and its many different expertise across the board. So I'm just really, truly delighted. It sort of made my day hearing you guys present your work and being excited about it. And I think I would agree with Erica that all of your work really has a tremendous amount of potential and has clear implications for patient management and patient care and understanding pathophysiology. So I really just want to commend you on your work and keep going and continue to be part of the assembly of the AII Assembly. I think you'll find in our ranks really great collaborators and opportunities to network and broaden your opportunities to work with additional people across other universities. So our representation is very broad. So please do come to the assemblies and participate and continue to do great work. I have maybe a couple of questions, but I don't know if we have time.
Please, we have till 12, so please feel free.
Oh my goodness, let me see. All right. So I have a question for Leander. Maybe a couple of questions. So I think I agree that with I think Erica just mentioned something that what would really be wonderful is to see the changes on CFTR modulation and the immune response in monocytes. How does that play on a viral challenge model? And to see how that really impacts the capacity to clear viruses, for example. That would be super interesting. No, I'm not a CFT. I mean, I'm just a sort of an asthma person, but I understand that there's some degree of variation. There's some degree of variation and heterogeneity in the response to CFTR modulators. Can you tell us a little bit about whether or not you see that in terms of interferon TNF responses across monocytes in patients? Do most people, once they get into treatment, sort of achieve this immunological imbalance correction, or do some people respond and others don't respond? And do you have some insight into that?
Yeah, absolutely. Thank you for the question. So as I also mentioned in my presentation, in terms of like the upregulation of the interferon signaling on ETI, was mainly in a subset of patients that had the most severe baseline inflammation, right? So it seems to be also, and this is a known phenomenon, that chronic inflammation, also chronic exposure to LPS in the airway, induces a sort of state of immunoparalysis also. And also blunts actually like interferon-related responses. So it seems also to be, I think, due to decrease of the bacterial load in the airways, probably that your immune system or parts of your immune system wake up again a bit, right? But this response is very heterogeneous, as you mentioned. And interestingly, also what we see is in clinical practice that some patients who start on ETI actually respond more severely than before to certain viral infections, which is also, I think, a very interesting clinical phenomenon, right? So, like in terms of like influenza infections in CF patients before they were started on modulators, it was usually pretty mild, just like the course of the clinical influenza infection. They had an exacerbation of their underlying Pseudomonas that they had. But now what we see is actually severe influenza infections with like classical complications such as pneumococcal pneumonia. But not in all patients. And then in some other patients who have like NTM infections, which is also very interesting, and which are also like the clearance of NTM infection is also related to like the degree of interferon in your airway. We see some patients who clear their bacteria, other patients who don't. So I think that's like definitely an area of research that needs to be further studied and like clarify like what explains these differences in terms of response. So yeah. Great question. Thanks.
More research questions, right? The next project.
Of course. Yeah. Always welcome.
Erika, you have other questions? Tetsuro, I don't know, or Sarah?
Well, maybe this is a random question. For Dr. Boers' topic, I mean, we see lots of HSV, if we do like BAL, like in these patients, obviously we do not do, for clinical reasons, we just happen to, collect them and, see some, reactivation versus true infection. I just wonder, like, do you tend to, collect BAL like cells, for cytology analysis and see if there's like any signs of actual infection of HSV versus not, or is a common thing for you to do for research projects?
So do you mean if it's common for other hospitals to collect these data, or?
Yeah, like collect the BAL cells and look at the cells cytology and see if there's a multinucleated cells, suggesting actual infection versus, not, which would be just HSV, PCR is high, but not necessarily infecting the lung cells or,
Could you maybe repeat the question? I'm not sure if I understand it.
Like you see the PCR titers for the HSV, but like is there any way that you can differentiate between just the reactivation being there, but like bystander or the inflammation versus HSV actually infecting the lungs?
Mm-hmm. Yeah, so the golden standard, of course, is to do a biopsy and to see really in the lung if it's pathogenic. And there were previous studies that did these kinds of analyses, and based on those, this cutoff of 10 to the 4th copies per ml was defined. But this was in different populations, such as immunocompromised patients. So it's not really discovered yet in this population. But in my study into COVID patients, I also did a cutoff analysis, trying to see if the association with mortality was different using different cutoffs. And there it seems that using the cutoff of 10 to the 4th was the best predictor of worse outcomes.
Got it. Like, would you treat those patients with like anti-HSV drugs?
Yeah, we do. In Amsterdam, we do treat the patients from this cutoff. Yeah, from this threshold to the 4th. Below that, we don't treat it. And from that threshold, we treat every patient.
Got it.
Yeah, but it's fair. I think in the most hospitals, people don't even look for HSV. So I think there is a lot of different opinions throughout the world about this topic.
And
do you have any data whether treatment makes a difference or?
Well, there is a RCT currently going on that compares patients with threshold of HSV reactivations from 10 to the 5th copies per ml. And then treatment versus no treatment. But yeah, the expectation is that this study will enroll patients for several years. So I don't think we have a soon answer, but yeah, I'm very eager to see those results.
Very interesting.
Yeah, thank you. I think that's the key question that will
Yeah.
change all of our practice if we find out that it's protective. Well, again, thank you so much to all of our speakers, our expert panelists, and all of you that joined. I really enjoyed this conversation, and thank you so much to the AII Assembly for sponsoring this webinar. If you guys have any ideas for future speakers or topics, you can reach out to our ATS Assembly web representative and submit your ideas. And with that, if there's no other questions, we can conclude the webinar. Thank you so much and have a great day.